from Germany, and he got his original medical degree from the University of Hamburg, and was able to go through his residencies in many university hospitals and clinics throughout Hamburg, Berlin, and London, England. But now we're fortunate to have him here in the U.S. Dr. Dierks has taught at the University of Chicago Medical School and is now the chief of the section of nephrology at Alta Bates Medical Center. Dr. Dierks is a very busy man. He is also medical director of the hemodialysis unit at Fresenius in Peralta, and a member of the board of Dialysis Access Center in Oakland. And he serves his patient, and I'm sure that you've seen him in this role as a part of the Chabot Nephrology Medical Group in Oakland. So, without further ado, Dr. Dierks.
Topic today, I'm speaking about why it's a good time to be a kidney patient. I picked a variety of topics that I thought could make a difference in the life of kidney patients already and will be in the future. The internet. How does the internet changes your patient-patient and patient-doctor interaction? How can it empower you? What are the benefits of good evidence and its influence on making clinical practice guidelines that help us treating you? How can we reach out and integrate other forms of treatments in treating our patients with kidney disease? Is Western medicine the only option? Frequent home hemodialysis, we've heard a lot about it, and I'll digress on that a little bit more. How far are we to create immune tolerance in organ transplantation? I'll talk a little bit about the results of newer trials from Stanford, Northwestern, and Harvard. There's new device technology on the horizon, which is very exciting. I'll talk about the wearable kidney and the artificial kidney project that's supported by the FDA. And we'll talk a little bit about organ reproduction, 3D printing of organs. What's so good about bad renal function? Does anybody have an idea? I actually borrowed this from Carl Kjellström, who's a very influential, now retired nephrologist from Sweden. He presented in front of our fellowship group 10 years ago. This is the winner of the so-called Birkebeiner cross-country, long-distance ski race in Norway. Was a dialysis patient and won the race in his age group. And he won because he didn't have to go to the bathroom. The internet. The internet changes the life of all of us. We shop on the internet. Some find love on the internet. We pay our bills on the internet. We search medical information on the internet. Tom Ferguson was instrumental in the e-patient movement. He defined e-patients as patients who have access to the internet and search health information on the internet and look for a different patient-doctor relationship. The E in front of e-patient stands for equipped, engaged, empowered, and enabled. This is the cover of the British Medical Journal from 2010. in which the patient, so-called e-patient Dave, was publishing his experiences just being diagnosed with widely metastatic kidney cancer. He was told that he doesn't have a whole lot more to live. He was given an internet address of a patient listserv called BAAKP. Very quickly, he received so much information that not only does he know now that there's a treatment out there, high-dose interleukin-2, that works in up to 20% of patients, he also gets 4 telephone numbers of doctors who can actually give this to him. Now he wants to be prepared, so he goes back to acor.com and says, who of you have received the treatment? 2 hours later, he has 17 responses of patients sharing this with him. The experiences going through this very intense, not easy therapy. So he felt empowered and ready to get the treatment. Now he's cancer-free. A couple of points he's making in his TED Talk as well is only 1 out of 4 patients with renal cell carcinoma, in fact, knew about the treatment. acor.com gave him more information than he received from his own medical center. He also said, you should own your data, your medical information, and we'll get to that a little later. Now, this is the website of the Bay Area Association of Kidney Patients. Ben already gave everything away I wanted to say. But really, I find this very useful for my patients, for myself. They get support. I think the video series is just superb. And this is actually the group of board members who arranged this meeting. Thank you. I created the term kidney e-patient because I think the Bay Area Association of Kidney Patients are kidney e-patients. So we have access to various patient-run organizations, patient networks, support groups, American Association of Kidney Patients and Bay Area Association of Kidney Patients, and more. There are 30 nephrology blogs on the internet. 18 of them are selected by the American Journal of Kidney Disease blog. Those are updated frequently, and 3 of them, in fact, are patient-run blogs. They're educational videos. Some of what I'm talking about is presented in detail by researchers who actually lead the project I'm talking about. Artificial kidney project, wearable kidney, some of the DNA printing information is all on the web. You have access to clinical practice guidelines, and I'm telling you how to access this. Other valuable resources, the National Kidney Foundation is a very useful resource for you. You have access to educational material on your nephrologist's website. We have a great educational site for you where we explain every little piece of information for you. What I found the most valuable departmental website is the University of North Carolina, Chapel Hill, where Ron Falk is chief. Electronic medical records. You have the patient portal. You can access your electronic medical records. I just learned about this OmniTimeline.com app that one of my colleagues in the back, Dr. Martha, created. You can create your own medical record with your iPhone. It's an app you can download and use. You can scan your EKG, your reports, anything you want. I know it can be cumbersome, but I think it is a very useful tool, and it's a free app. Here's some information for you. So this is a patient of mine who, before she is to undergo, or was to undergo, a very important surgery, was swimming to Alcatraz and was grilling marshmallows on the bay and was escaping before the police could catch her. That's a true story. Evidence-based clinical practice guidelines. Evidence-based medicine is a movement that goes back to the 70s and 80s, where there was demand for better clinical evidence, better designed trials. We needed statistical analysis to read or to design trials, so-called randomized controlled trials, where the participants are allocated randomly to the groups and to reduce bias. And I think the trials we're actually looking at nowadays most of them are randomized controlled trials. And that helped us to create clinical practice guidelines. Now there's a great variation of actually medical care in nephrology, and clinical guidelines will help us to improve the care to our patients. Now, guidelines were initially started in 1993 by the Renal Physician Association, just limited to adequacy of dialysis. 1997, so-called Dialysis Outcome Quality Initiative with the National Kidney Foundation was giving us guidelines of how we should take care of a patient on dialysis only. That was expanded to kidney disease outcome, where management of chronic kidney disease and acute kidney injury was added. Now this all expanded into a global guideline where international experts in the fields were getting together and giving you evidence in form of the so-called KDIGO guideline, and this is available on an iPad. The evidence is graded, so strong evidence is a strong recommendation. Weak evidence is a suggestion. So I think that is very helpful. Now, clinical practice guidelines are good, but do they fit all? It does not diminish the importance of what I call the art of medicine, the clinical expertise, the experience. I always admired Peter Falk as Columbo because he was so persistent. He asked questions, sometimes to a painful degree. Cases of fun. This case is simple because a simple intervention leads to improvement of the patient and improvement of outcomes. 70-year-old female with so-called weak heart, high blood pressure, diabetes, coronary artery disease. She moved from Boston recently, was referred to my office, and she had a creatinine of 3, significantly impaired renal function, about 15% of kidney function. Looking at the urine is very important. It's almost like a little kidney biopsy. What is actually happening in the kidney? The urine was entirely normal. I didn't have any other lab results. So now Columbo needed to be in action, finding information that is very important. Am I settling for the fact that she has only 15% of kidney function without really explaining this well enough? So after a couple of phone calls during her consultation, we came up with some information in Boston, so we have a very helpful physician there. It turns out she had almost normal renal function before she had an intervention 6 months prior. And after the intervention, meaning an implantable device to shock the heart when necessary, called defibrillator, her kidney function worsened to 2.6. So over 6 months, her kidney function was abnormal. I couldn't explain it. So I said, we need to have an intervention. She was on furosemide, which is a diuretic medicine. and on medicine familiar to you, BAAKP, a receptor, and angiotensin receptor antagonist. Say, well, our physical exam was entirely normal, no signs of a weak heart. I said, let's cut the diuretics, let's stop the BAAKP, and let's see you back in a week and recheck your numbers. And it turns out that her kidney function now is very close to what it was in the beginning. So guidelines are good, but I think individual care is still very, very important. And curiosity, can I accept this or not? Healthy perspective. I think many don't know that most of the patients we see are patients in the outpatient setting. Only about 5% and less of our patients are on dialysis. A large proportion of older patients have sometimes significant impairment of renal function, but no protein in their urine. Apart from polycystic kidney disease, the likelihood of them to progress is very low. That's my experience, and that's the experience that's documented in the literature. There is good news. There's decreasing incidence of the rate of dialysis over the last 3 years, and there's lower mortality rates on dialysis. Integrating traditional Chinese medicine. So I've been a patient with my wife, so I can speak of my own experience. So she helped me many, many, many times. I sent numerous patients to traditional Chinese medicine practitioners, and most of them come back with very good results. Now, these are very common symptoms patients with advanced chronic kidney disease have. Can't sleep, they have pain, they have cramping, they have musculoskeletal complaints, there's infertility, there's itching, nausea, vomiting, fatigue, and weakness. Now, we can give tablets for each of those. That will increase your pill burden from 20 to 30. I don't think anybody is really interested in that. Now, this is a note my daughter wrote to her teacher 3 months ago. Let me read this to you. Hi there, Ms. Camp. Yesterday you weren't there, and my throat got really sore and hurt a lot. My mom is an acupuncturist, and she has a solution to everything. Anyway, she has these drops that I need to take if my throat wants to get better. So I was wondering if I could suck on them in class, the drops. Yes, this was a very badly spelled note, and the drops taste bad. Now, acupuncture, you may think this is hocus pocus. There is good evidence, so we can use clinical Western tools to assess Eastern medicine. And we've done that with so-called functional MRI studies. So your brain is scanned with a magnetic resonance imaging, and you see wherever the needles enter the body, certain parts of the brain light up that are responsible for certain symptoms. Acupuncture helps in chronic stress in laboratory animals. I think the most convincing is this large, we call it meta-analysis, where many trials are pooled in one with 17,000 patients, where there were 2 groups. One was the treatment group and one was the so-called control group. And sham group means they thought they would get the treatment, they didn't. And this was clearly statistically significant. Now let's switch gears a little bit to dialysis. This is the rotating drum artificial kidney invented by Willem Kolk, a Dutch physician, and this is the first treatment on the drum published in Life. 1962, Dr. Scribner opened the first outpatient hemodialysis unit in Seattle with, I think, 9 patients. He invented the so-called Scribner shunt. It's a tube that went into the artery and was giving blood back into the vein, but it was kind of surgically implanted, but it just is outside the body. So it's not an ideal solution. And there was an incident when a 15-year-old girl needed dialysis and couldn't get in because there were not enough dialysis spots available. So Scribner worked feverishly to find a solution for her and was devising a machine that she could use at home. Ethics committees were necessary to allocate patients to dialysis because we didn't have enough spots. So Scribner was smart enough to basically pass this on to community leaders to decide who will get dialysis and who will not. Now, luckily, in 1972, Congress passed the ESRD plan under Medicare, where all dialysis was covered by Medicare.
Yes.
So it's always good to kind of go back to the past to see what we have now. Now, those are 2 dialysis machines. Some of you are familiar with the left one from Fresenius that's mainly used in the in-center dialysis. And then on the right-hand side, Alvin so eloquently went over next stage. Thank you. We have made progress. Have we created a breakthrough yet? Not really. We have filters that work. They were invented in 1972. They're still very similar to the filters we're using right now. But I think we have made progress in emphasizing home therapy, and I'll go through the advantages a little bit with you. We have an excellent infrastructure. We have nurses who care for you 24/7. If you have a problem with your machine, you're not feeling well, these nurses are on call for you. They provide excellent training to you. Other benefits are volume control. It means if you have weight gain from one day to the other, in-center dialysis, you will need to take off 2 to 3 liters. If you do this daily over a longer period of time, you prevent things that we see frequently in the in-center unit, blood pressure drop, something we call intradialytic hypotension. That can lead at times to what we call heart stunning. The heart is stunned, overwhelmed with the amount of fluid they're taking off in a short period of time. Now, phosphorus control is a lot better. Philip, I don't think he is on any phosphorus lowering medication right now. So we can remove phosphorus a lot better with home therapies, home hemodialysis. We can clean the blood a lot better, and we live longer on the therapy. My experience is very positive. Unfortunately, only 1.7% of all patients on dialysis are on home hemodialysis. We have another one in the back who just started. This is a patient of mine who's in the audience, and it's a very inspirational story I just wanted to quickly share with you. He had lupus, and an autoimmune disease, has affected his kidneys so severely that he required dialysis. He, in fact, was on dialysis for 6 months and underwent therapy with a chemotherapeutic agent, cytotoxin. And when I visited him in the in-center dialysis unit, once in a while he would just be on the phone and he would pray with a group of friends and support. And I was always impressed with his hope to get better. I personally was skeptical, because you have to weigh, is what we're doing really helping him, or are we harming him with therapy when there is no improvement of renal function? And together with the rheumatologist, we made a very difficult decision to press on and go. He, after 6 months, came off dialysis, and he has now a creatinine of 1.2 or 3, and was running a cross-country marathon, and I just downloaded this picture 2 days ago. So let's talk about immune tolerance in donor organs. This is a very complex topic, and I hope that I'm not over your head with this. I'm going to be trying to go slow. Organ transplantation, in my mind, is still the gold standard of therapy for patients who require dialysis. Only 20% of the patients who need a transplant organ, in fact, get it. There are 180,000 patients on the transplant list, and only, actually 90% of our kidney patients. The wait time in the Bay Area is between 3 to 6 years for a cadaveric renal transplant, maybe a little more. 50% of the patients who get a cadaveric kidney transplant, cadaveric means you get an organ from somebody who passed away, instead of living related, meaning a living person donates one of his kidneys. So 50% of the patients who get a kidney from somebody who passed away and donates it to you is 10 years. Currently, organ transplants are only possible with immune suppression medication. Those are very important, but those have also certain effects and side effects. And there is the movement and studies that allow us to withdraw immune suppression after about a year, and I'll talk about those. Now let's go to the basics. On the left-hand side, you see a lion with a giraffe's head. This comes out of the Greek mythology, and it's called chimera. So it's an animal that has two different parts in one, a giraffe and a lion. How can that be? This is actually the mascot of the American Society of Transplant Surgeons. And what chimera is and how it's used, I will show up top here, right here. These are observations from a physician in 1945, Dr. Owen, who observed that adult, non-identical cattle had two different red blood cells in one. So the immune system tolerated the other red cell. And that's called chimera. And his theory is, and what turns out, is that in utero, not born yet, the placenta was fused, so red cells could travel from one animal to the other. And this was in the setting of an immature immune system. So the immune system is about to mature. So with that maturation, the immune system learned to accept it. Now, those findings were very important and published in Nature in 1954. Dr. Medivar, in 1954, took those observations and injected cells of a non-identical mature mouse into an unborn mouse. It's basically a bone marrow transplantation, if you will, on a lower scale. Over the years, the unborn mouse, now born and getting mature, accepted those cells. He transplanted skin from the donor to now the mature mouse, and the skin was not rejected. So that observation was awarded the Nobel Prize in 1960. Now, what's the challenge? The challenge is to replicate what we found in an immature immune system in a mature immune system. So not much later, there were studies done in almost all animals where total body irradiation, so you irradiated the body of the recipient, reducing its immune response. And with the bone marrow transplantation, you could create exactly what we've seen in an immature immune system, creating this chimera I was referring to. And I hope it's not too complicated. Now, developments were done to condition recipients. We need to reduce your immune system at the time of transplantation. That can be done with chemotherapy. And it was found that chemotherapy reduced the need for the total body irradiation. So you can't be, irradiation obviously has side effects, so we want to lower it. Chemotherapy can lower your need for radiation. And also a very important finding is that when you give bone marrow to one patient, in order to create tolerance, you don't need 99% of cells of the donor, like in bone marrow transplantation we use for cancer treatment. That was kind of the critical point. So your conditioning doesn't have to be as aggressive as we see it in bone marrow transplantation. So all of a sudden, organ transplantation and bone marrow transplantation are crossing paths. And the results of Stanford, where they use living-related donors, Northwestern, where they use living-related and living-unrelated donors, and I think Harvard's not quite sure whether they only use living donors, have very promising results. 50% of patients can be weaned off immune suppression medication after this therapy, which long-term data are obviously not available, but you can live with an organ without immune suppression medication. Now, this is a patient of mine with his wife, who turns out to be a patient of mine as well, visiting Northwestern, and he will receive an organ from a donor, and he actually created a blog, alskidneyride.wordpress.com, where he describes his journey, and I'm sure he will do well. So this is a busy slide, just showing what Northwestern is going to do. We're going to take bone marrow cells from the donor and infuse it into the recipient right after organ transplantation. But Al is going to have to be conditioned. He will have radiation, low-dose body radiation, and he will get chemotherapy to reduce his immune system at the time of transplantation.
Are we still friends?
Why, of course. Why would you ask?
I just don't want you to feel insulted when I tell you to leave. You're leaving.
Yes, sir. Oh, sir. Just one more thing.
No, Lieutenant, there is no just one more thing. Goodbye.
Just one more.
Actually, there is. So we talk about advances, but have we had a breakthrough? No, we are waiting for this breakthrough. The FDA realized that and is working with inventors very closely to create this breakthrough. And we're very fortunate to have researchers at UCSF working on the artificial kidney. We'll talk about that later. So there were 33 projects applying at the FDA to be supported. Only 3 were selected, and I'm talking about 2 that are, I think, the most important. One is an access trial that I'm not going into. The wearable kidney project in LA, Dr. Gura was working on the wearable kidney and was able to miniaturize the kidney that you can wear, and I'm going to show it in a minute. This thing is less than 10 pounds large, 5 kilograms in weight. Batteries are important to feed the pumps, and the weight of the pump is only 300 grams. I think the key here is that the so-called dialysate, the fluid that moves across and passes the blood in a filter, which is your conventional dialysis filter, is regenerated. So sorbent filters are filtering out toxins and phosphorus, and will basically, the dialysate will then move and be enriched with potassium, calcium, bicarb. So it's a constant cycle. The downside on this is, maybe it's looks, but the problem is that the trials are only done with a catheter, something we want to prevent. But since in the original European trials there was venous needle dislodgement, so if you put needles in your arm, in your fistula, and walk around, then there's a higher likelihood of those needles just coming out of your arm. Now, the artificial kidney project. Dr. Shubal Roy, who is a professor in the Department of Bioengineering at UCSF, has spoken so eloquently about this, I think, at the beginning of last year. Unfortunately, it wasn't videotaped, but you can access a talk he gave at a transplant meeting in Sonoma on YouTube. So he has this 45-minute presentation, similar to the presentation he gave to the BAAKP, so you can listen to that. He described this very eloquently. He's very humble, very great guy. So this is the device that's smaller than a coffee cup. It will be implanted almost like a transplant organ with a hookup to an artery, and to a vein, and to a bladder. It has 2 components. One is the so-called filter component, and the other one is the so-called bioreactor component. And I explained to you what that means. Now, the basis of these studies that were done in animals, and animal trials started last year, is a study that was done on humans at the University of Michigan, where patients in the intensive care unit were allocated to a group with intense therapy, the so-called renal assist device, and a normal therapy. The renal assist device group had an additional filter with cells coming from the kidney cells, having a metabolic function, and reabsorbed some of the fluid that was pumped through. And the results of the trial were surprisingly positive, 50% lower mortality rate on the renal assist device. So Shubal Roy and Dr. Humes and Tumlin were working on a miniaturized version, and silicone microfabrication has enabled us to miniaturize the filter and put it into a much smaller device. And I'll tell you a little bit about the filter, which is stunning technology. The bioreactor part will be fed by kidney cells that will come out of a kidney biopsy, either from a loved one or from discarded kidney transplants. The initial cost of that device will likely be less than a kidney transplant, and the operational lifetime is probably around 10 years. So this is Dr. Roy, who is holding this microwaver, and the actual filter will be smaller. So the structure of this filter is very close to what our little pores are in the tubular cells, 7 nanometers. Each of these little yellow chips you see have 10,000 membranes. The structure is called parallel plate structure, and the key is that the filter has a very low hydraulic permeability. What does that mean? You can filter the blood through this with very little resistance, meaning this is much more efficient than our standard filter. So 20 times more permeable. Also, albumin, like a protein, will not be lost through this filter. And one other key element is that blood will not stick to it. So they came up with a little layer that will basically prevent protein, blood, to adhere to it. The FDA allows this trial only with anticoagulation, means blood thinning medication. But the hope is that this will be, that we are able to do this without blood thinning in the future. Now the cell bioreactor, this is basically the part where true cells are layered on a silicone filter, on a silicone surface, and only 1 gram of kidney tissue is necessary. And the key is that one could replicate those cells, expand it 17 times, and store it to keep its, what they call phenotype, its original structure. These cells take over metabolic functions of the true kidney. Hormone production of erythropoietin to build red cells, vitamin D production, and reabsorption through an active process. There's also something they come up with which is called immunoisolation. I don't understand it entirely, but what I read is that you basically coat the cells with another membrane so it's sheltered from the immune system, so that you don't need as much, if at all, immune suppression medication to keep those cells alive. So Lieutenant Uhura is asking Spock, what is in the future? 3D printing and organ reproduction. That would be the ideal scenario, right? That you're able to print your own organ, your own specs, implant them whenever you want. Now this is a picture, the hand of Anthony Atala, who was a urologist at Wake Forest University, holding a 3D printed organ. This was a talk, if I'm not mistaken, a TED Talk from 2009, where he was sharing with the audience his experiences to reproduce cells. Stunning trials. He treated patients who were born with a malformation of the spine, leading to what we call non-functional bladder, requiring dialysis. But they still had bladder cells, so he took the bladder cells of these 10-year-old kids, reproduced them, lined them up on a scaffold, grew an entire bladder, and was implanting that bladder into those kids. And in that TED Talk, there was this 20-year-old who had this implanted 20 years ago and came off dialysis. Very stunning. Now, so the hope is to print kidneys. Professor Jennifer Lewis, who is one of the leaders of reproduction as well, said it's going to be a moonshot. We're coming closer. What she has done is she created a way to build blood vessels around tissues. So she was reproducing cells and left little holes for the blood vessels, and was then able to inject cells that create blood vessels of a diameter of 75 nanometers. So that is a huge step in the right direction. Now we can 3D print, and we can send emails to space to print wrenches. So this is the first time an astronaut was printing wrenches. We can print everything. I think you can go on, you can go online and print certain things already. Now this is an article from the New Yorker in November last year, basically describing how far we have come in printing, 3D printing. I highly recommend to read this. Now the next step, and I think what's really kind of important, is this finding of a Japanese research group who were able to grow an entire little filtering structure called nephron. We have 1 million nephrons in each kidney, one on the right, one on the left. This is a functioning part called nephron, with a little washing machine, the entire tubules. So if we had 1 million of those with the blood vessels together, we would have an entire organ. Julia Lewis at Harvard said, it's not a matter of if, it's a matter of when we can do this, and it may take us 5 or 10 years, but I think the future is bright. What did I tell you? I told you a little bit about the tools to empower you as patients, the importance of practice guidelines, and that we basically care for our patients uniformly, the value of other therapies that can help us manage our symptoms, intense home hemodialysis, an underused modality that I think we should look very close into as somebody who who needs to start dialysis. Obviously, ideally, you get a so-called preemptive transplant. That would be, and that's actually a point I had not made, is that you can register and enroll into a kidney transplant program if your kidney function is at about 20% of normal, far before you need a transplant. So it's very important information that you probably already have, and if not, you need to strongly consider this. How far have we come to create immune tolerance, new device technology with a wearable kidney, and the artificial kidney will likely revolutionize the way we treat patients on dialysis, and something closer than a moonshot, 3D printing of kidneys.